Welcome to this month's True Conversations. As many of you already know, this is a webinar series hosted by Rx Health Strategists. We are a people-first PBM that brings innovative solutions to our clients and our partners to turn your healthcare costs into health investments. We really are here to help make people healthier, and today's topic is all about that. I am Adrienne Laborowit. I am our Chief Strategy Officer at Rx Health Strategists. But a little bit about our company before we dive into the webinar. Rx really aims to be more than just a PBM that processes claims. First of all, we are owned by a family of pharmacists for 5 generations. So we've had pharmacists in this business since the 1800s, which is a very unique story. Our success really stems from our commitment to providing genuine care for people when they need it most. As health strategists, we are clinically trained partners that take a patient-first approach to healthcare costs and cost management. We are on your side because we understand the challenges you face as consultants, as employers, and the importance of support during critical times. Through personalized care, we empower patients and employers to thrive, ensuring that together we can turn obstacles into pathways for health and success. So we're all about putting the patient first. We really want people to be healthier. We know that that is truly the only way we're going to impact the bottom line. We know so many employers and brokers and consultants are helping to help manage healthcare costs, which continue to rise. And today's topic is points to that. Our topic today is the diabetes dilemma, a blueprint for employers to lower costs and complications. Today, 1 in 4 healthcare dollars in the US are spent on patients with diabetes. And I think even a more staggering statistic is 1 in 2 people are either overweight or obese. So for many of you, especially medication costs were a top concern for you, maybe over the last 5 years. That's 1 to 2% of your population that take those medications. Diabetes and prediabetes really impacts such a broader scope of people on your plan and in the US today. So this is a very relevant topic for many of you, and we're here with our wonderful panelists to help you navigate this. And with that, I will introduce our panelists today. So first of all, we have Chelsea Journal. She is our Director of Clinical Solutions at Rx. She helps manage and operate the Rx Diabetes program and also all of our other clinical programs. She is fantastic. She is a pharmacist, and so happy to have her on the panel today. Our second panelist is the lovely Barbara Eichhorst. She is the Vice President of Healthcare Programs at the American Diabetes Association. Who better to speak on this topic than Barbara and her expertise at the ADA. Our next panelist is someone I'm very proud to introduce, Amy Haug. She is Chief Human Resources Officer at Cardon. It's an assisted living facility located in Indiana. She actually, Cardon is one of our clients who have adopted our diabetic program. And so again, who better to speak on this than someone who is actually seeing the impact as an employer on her members and the power of how managing diabetes can impact your business. So with that, we will get started on the Q&A. Again, this webinar is titled True Conversations. That's very intentional on our part. We really want this to be a conversation, not just with our panelists, but inviting our audience to dive in. Ask your questions. What are you concerned about? How can we help while we're all here together? That's really what this is for. So with that, I will start the Q&A, but I'm going to be asking Barbara to kind of take a deeper dive in understanding the diabetic epidemic. In fact, the ADA indicates an average medical costs are 2.6 times higher for patients with diabetes, averaging an additional $9,600 a year. So again, those healthcare costs continue to rise because of these health conditions. Barbara, the ADA indicates diabetes is an epidemic that impacts over 133 million Americans. What is driving the prevalence of this disease, and what factors should we be looking at I'm sorry, these factors that drive the prevalence of diabetes significantly impact A1C levels. How can you talk about what an A1C level is and why it matters?
Thank you for asking that, Adrienne. That's an important question because we do want to better understand what is driving the high prevalence of diabetes. Typically, it's a social determinants of health. It's a lifestyle, it's obesity, environmental issues. So it's our body is like, a loaded gun. We have the genes that predispose us to diabetes. However, the environment pulls the trigger. So if we are living within communities where there is no access to healthy food, processed foods, foods that are unhealthy, and then people can consume more of it, and as a result get obese, and then consequently get diabetes. There's also other elements like a daily stressor of life can contribute to getting diabetes. So it is very environmental, the way that we get diabetes. When people are diagnosed with type 2 diabetes, we typically have pre-diabetes for about 10 years prior to that. So that's now we consider pre-diabetes as a medical condition. So just like obesity is a medical condition that people are diagnosed and treated for, pre-diabetes is also considered a medical condition. And when you ask about the A1Cs, A1C is typically used to indicate the blood glucose measurement for last 2 to 3 months. And we use it now we use it to diagnose people with pre-diabetes and diabetes. And it's also used to better understand like how medication and the treatment it helps to get better with diabetes.
Excellent. Thank you for laying that foundation. You know, you can't talk about diabetes without mentioning A1C. And so it's so important to understand that from the ground level. Because this is such a big topic in our country today, it's a big health concern. Want to dive into some of the myths or misunderstandings you see about diabetes that you deal with at the ADA and kind of debunking those for our audience here today.
I think that the best misunderstanding is that, let's say, eating too much sugar or somehow being obese on other things causes diabetes. That's why we want people to know that if they have a predisposition, but there is a lot of factors. They do have the gene, we inherit it, and then we're more likely to get diabetes also. Some of the semi-misunderstanding could be that diabetes is reversible. Like you can, when you get a surgery, you lose weight, then you no longer have diabetes. You still have diabetes, however, your lifestyle managed, because it can come, you can come back. And then there is a lot of misunderstanding about insulin or medications. Like people think that they're doing worse if they're on more medication with diabetes. And that is in fact not the case. Typically, when we take more medication, it's a good thing because physiologically, diabetes is not just caused by one thing, and different medications address different cause or different pathophysiology of diabetes. And that's why people are on it. And then there's a lot of misunderstanding about the A1C or blood glucose management. So it's typically with a diagnosis, like a lot of times we say we have borderline diabetes, which doesn't exist because we cannot be borderline pregnant. We either have it or we don't. So because of some of those myths, misunderstandings, and people often do not seek appropriate care. So it's very important to help people to kind of see the reality. The bottom line is with a diagnosis of diabetes or pre-diabetes, typically fasting blood glucose is being done on all of us every time we go to do our labs done. So anything between fasting blood glucose between 70 and 100, that's within a range. we no longer say normal, because we don't want people to think that if the blood glucose is elevated, they're not normal somehow. That's why we say within the range or outside the range, but not the normal thing, because it's and then anything between 100 to 125 fasting blood glucose is considered pre-diabetes, and 126 or above is considered diabetes. So those are very important things to keep in mind and watch for people when they are having their labs done. And then also A1Cs, as you mentioned, are also used to monitor diabetes management, but also to diagnose diabetes. So we know that less than 5.7 hemoglobin A1C is considered a non-diabetes, and 5.7 to 6.4 is considered pre-diabetes, and 6.5 or above is considered type 2 diabetes. And hemoglobin A1C is in a percentage range because it means it's the amount of glucose attached to the hemoglobin. So it's a concentration. So if you think about having a blood, and then there is more blood glucose circulating in the blood, more blood glucose is kind of sticky, so it's going to attach to the hemoglobin and other things that makes circulation much harder for people with diabetes. So that's why it's in a percentage. So we want to have a blood glucose an A1C as close to non-diabetes range as possible. So the goal of diabetes management is to be as healthy as people without diabetes. And that is actually a very common myth, because people often think that people with diabetes are less healthy. And many times when they get diagnosed with diabetes, they get on it, and then they monitor their blood glucose, they adopt healthy lifestyle, and oftentimes they're more healthy than people without diabetes.
So they're kind of forced to really take care of their health, looking at their sugar levels and exercise and how they eat and all of that. Probably more mindful of that than the average person.
Sure, that's exactly it. And these days, we also have access to continuous glucose monitoring that people can start using, and then get the real-time data on their blood glucose. So even before they develop diabetes, they can use that because now it's indicated for weight management, and you don't have to have diabetes to start using it. But those continuous glucose monitors are very effective to provide real-time blood glucose. So like if I have an apple right now, I can better understand where my blood glucose is, instead of waiting with the regular pricks on a finger for the next day, or 2 hours after. So it just shows, like after an apple, it goes up, but it comes down, 10 minutes after. So you have a real-time input about the blood glucose, so you can change those behaviors as a result of it, and you can modify it.
Well, Barbara, thank you for setting me up for a perfect segue, because we're going to be looking at emerging trends that are shaping the future of diabetes. So clearly the technology has changed so that people can better monitor this and control. But Chelsea, as a pharmacist, and with Rx's diabetes management program, you meet with patients daily. So you're on the front lines talking to diabetic patients every day. What emerging trends are you noticing in diabetes management, particularly in terms of new medications and technologies?
Yeah, absolutely. And I know we use the word trends, but I'm hoping that a few of these no longer stay trends, right? It's a change in the landscape of how we take care of patients. But Barbara just talked about continuous glucose monitors. They have really changed the game for how patients with diabetes can stay engaged with their blood sugars. Just a little review or background for those on the webinar that aren't familiar with them. Traditionally we think of patients checking their blood sugars by poking their fingers. And when you do that multiple times a day, it's painful. And they become bruised and they develop calluses, and it's not convenient to, think about when you are in the day-to-day of your life, to stop and check it at various times of the day. The continuous glucose monitor is simply a sensor that they can wear on the upper outside of their arm. It has a small filament that goes under the skin, and it is continuously reading it. They can download apps on their phone, they can use a reader, and it's constantly telling them what their blood sugars are. It really helps patients get engaged with how they are eating and what they are consuming. I've done diabetes education for 15 years, and it just helps the light bulb go off a little bit faster and a little bit quicker of what we educate about, because they are so in tune to it. When I have consultants and brokers and employers who ask me about it and coverage for it, I say it can be as good as medicine for some members. I see members who de-escalate medications or are able to come off some other medications because they have just become so engaged in eating differently and adopting a healthier lifestyle. So it is a trend right now. We are seeing that more and more employers are covering it. They are covering it not only for just patients who are on insulin. So I am hopeful that we will continue to see an improvement in acceptance in those continuous glucose monitors. It's also very helpful for those who are on pumps and on mealtime insulin. It alerts them of when they are dropping too drastically or dropping too low or on a really high spike to bolus some insulin, which is also going to help prevent someone ending up in the ER or having an event. So it can be really helpful to those more tenuous patients who have kind of a rocky blood sugar control or just more sensitive to lows than some of our other patients. I will say too, we're seeing a lot more biosimilars in the space for insulin, which is making insulin a little bit more affordable. I will say too, it makes it a little bit trickier for physicians to figure out what's covered for patients and patients to figure out what's covered by insurance and how they can get more affordable or what insulin option is the most affordable for them. But that is where we come in. I counsel almost every day, weekly, to patients on helping them navigate what's the most affordable for them. And talking and making those recommendations to providers to help the patients along the way. Or even we get phone calls from our clients, right? Helping us figure out what's on their formulary and what they should be prescribed. But the biosimilars are very much pushing those insulin prices to come down, which is great and makes it much more affordable for our patients. One other trend I would say that is not really a trend anymore. I think it's a very much an acceptance of care is a team-based care approach for our diabetes patients. Much more recognition in this space that they need a lot of touch points. Providers, it shouldn't fall solely on the providers in the office when they see them to take care of these patients. So they need resources. They need diabetes programs. They need a dietitian. They need a clinical pharmacist. It's very much now recognized as a team-based approach to take care of these patients.
Yeah. Such great talking points from how to manage costs and also how to care for the patient. It takes more than just one medical provider to provide the appropriate care that these individuals need. So thank you, Chelsea. GLP-1s is probably something that everybody on this call is working with today, figuring out how to manage those costs. Chelsea, talk about GLP-1s and their impact on managing weight and diabetes. As a pharmacist, from your perspective, what do employers need to know about GLP-1s today?
Yes. So that is one thing I didn't list as a trend, right? That is a social craze right now. With GLP-1s are everywhere. I figured we would get to that. I think first and foremost, it's important to recognize that the GLP-1s are FDA approved kind of for two different indications, right? So they are FDA approved for patients with diabetes, and those are a separate medication list than those that are FDA approved for weight loss. So first and foremost, having a prior authorization system in place so that those patients with diabetes end up on the medications that are FDA approved for diabetes, and they are not being used off-label. That's when we get in situations where there are shortages for those medications, those GLP-1s that are FDA approved for diabetes. We run into shortages in our patients with diabetes aren't able to get them. So first and foremost, that's important. And then also, if you do cover choose to cover GLP-1s for weight loss, making sure that there is a prior authorization process in place for that as well. So that those medications, those patients with obesity or overweight, end up with those GLP-1s that are FDA approved for weight loss and obesity, and they end up in the correct hands, as well as ensuring that they meet that FDA approved criteria. You know, it's not meant for everyone. There is BMI criteria. There's BMI criteria along with chronic conditions they need to meet. So just to ensure that those GLP-1s are ending up in the proper hands.
Absolutely. Chelsea, you've been talking about how complex it is to manage diabetic care. Barbara, from your perspective, what key factors are driving the need to rethink the status quo of diabetes care? How can embracing new approaches improve outcomes for patients and reduce overall cost?
I think I wanted to relate what Chelsea just indicated, and that is the need for a multidisciplinary approach for patient-centered care. And we call it access issue. For people to have access to the diabetes educators, for example, American Diabetes Association is a provider of diabetes self-management and education and support for people with type 2 diabetes, where they were eligible to receive diabetes education of 10 hours within a first year of diagnosis, and later 2 hours or more living with diabetes. So, but that's a program that is completely underutilized. Only less than 7% of eligible beneficiaries use that program. It's available. People can go and then receive the care from a pharmacist, dietitians. It's always multidisciplinary approach. So it's making people aware that diabetes education doesn't only happen when you're diagnosed, but it changes with time. So it changes as their blood glucose changes, and that changes when people have a transition in care, when they used to be independent living at home and now we're in a facility, for example, their diabetes is being impacted. Or there is the second thing is whenever there's a complicating factors arise, like they were very healthy with diabetes, but now they have a kidney condition, then they're advised to go back and see the diabetes care and education specialists in those centers. And they're available everywhere. I mean, we have just the ADA centers. There's 3,600 ADA recognized centers that people with diabetes can go and receive their care. Payers are reimbursed for it. It's fully reimbursable by Medicare and the payers. So it's not an issue of reimbursement. It's an issue of more of awareness that people don't realize that they have that resource available to them. But I think that that the big call to action for everybody who is here with us today is to be aware that diabetes self-management education exists and people are eligible for it, and they can always come to those centers and then get assessed. Then diabetes care education specialists will help to assess, like, hey, what medication you're on, let's reevaluate, get patient on continuous glucose monitors, GLP-1, and all of that other stuff. People with diabetes, typically they would go to primary care, but when they go to primary care, often those centers are affiliated with the primary care. So it's not just to see let's say a dietitian, because dietitian might not necessarily specialize in diabetes care. It's important to see a diabetes care and education specialist that could be a pharmacist, could be a physician, could be dietitian, could be psychologist. All of us are skilled in providing that individualized assessment of people with diabetes and helping them to coordinate their care.
Yeah, such good points, Barbara. And, you know, we've been talking about diabetic management from a disease state, patient-focused resources, community resources that the ADA offers. Amy, you represent a very important piece of the puzzle here, and that's the employer perspective. So all of these costs are coming to the employer, or a lot of the times they are. Your employees are managing this, you know, for their quality of life, for how productive they can be at work. So from your perspective, from a HR leader, the ADA reports reduced patient work productivity and missed work days accounts for $41 billion in annual indirect costs. How has diabetes impacted your organization in terms of cost and productivity?
I think I should start by saying I'm fortunate. I'm in a fortunate position as an HR leader to have a really good support team. I know Chelsea and Barbara both talked about that from a clinical patient perspective, but also from an employer perspective. I'm fortunate to work with a really strong broker. We use Gallagher, and of course, TrueRx is our PBM, because I feel like it all starts with awareness. It starts with me understanding the data behind what diabetes is costing us, at least what we can see, and we know. On our group alone, we have over 10% of our participants on our group health plan are actively receiving medications for diabetes. So we also know there's probably an equal, if not greater portion that fall into the prediabetes category or the untreated, undiagnosed diabetics. So we know that it's a significant portion of our population. We know that it is the biggest expense from a chronic healthcare condition. So we're battling that. What Barbara had mentioned in terms of comorbidity. So an employee has another situation that arises where they're getting healthcare, and then the topic of, oh my gosh, by the way, did you realize you're diabetic comes up, and then that's something that has to be managed kind of in conjunction with what other health condition they have going on. So we know it's a big expense. Probably arguably our most prevalent expense in terms of number of members that are impacted. And for us, it's been a matter of really getting our head around what do we do? We know that this is the situation. We've been partnered with TrueRx for a couple years now, most recently, and really using it as an opportunity to dig into how can we best support our employees? How can we best get them the resources, the education, reduce the barriers in terms of cost and access, and really, and I think we'll talk about it a little bit later, but the On Track program kind of opened the door to a whole lot of conversation about this, changing our culture, normalizing conversations about blood sugars and diabetes, prediabetes. What is this? You can't be kind of pregnant, right? Barbara, I'm not like, it's not that I don't need to take care of that now because I don't have it. Once you have the awareness of where you're at on that continuum, if you're on it, then you need to be dealing with it. So we've had really good partners. Yes, it's probably our biggest cost and impacts the biggest number of members. But I think over the past couple of years and 2024 for sure, we've just kind of had an all-out focus on doing whatever we can to address and support the people that are impacted.
Yeah, all really good points. I want to just hit on one thing you said. You said we can see the costs, at least the ones we know about. And really want Chelsea to dive in here on this. What are some of the hidden costs of diabetes that employers may not know about? What, you see the drug cost, but what are some other things that employers need to be mindful of when you're thinking about diabetic cost?
Yeah, absolutely. And you're right. I think first and foremost, we see an employer sees on there, well, these medications are the most expensive. And they are more expensive than treating some other disease states. But what I have conversations with employers about is, this set of your population, your employees are at a significant increased risk of complications. Just as a baseline of being a diabetic, you're at a significant increased risk of heart attack or stroke, chronic kidney disease that I know Barbara touched on. And if you are uncontrolled diabetic, that is the increased risk is even higher. So it is so important to take care of that population because it can stem from just those medication costs to something much larger. So if they develop these complications, they're not short-lived. It's going to lead to more medications down the road, more procedures, more hospitalizations, increased risk of even more added increased risk of ending up in the emergency room. So that can add up and increase your healthcare expenses or your medical expenses even more. I would also say, we have those indirect costs, which I think you touched on a little bit. When your diabetic members are controlled, they are going to be more productive in your workforce. And they are also going to have less missed days of work, which is huge. There are some really staggering statistics of lost productivity for those employees with diabetes who are uncontrolled. And I know Amy has seen that even from being in our program. She has mentioned, you know, there are some employees that she has noticed are more, I wouldn't say more productive, but she can tell a difference in them. They are happier. And if you have a happier employee who is feeling better, I guarantee you they are going to be a more productive employee for you.
Absolutely.
I can also add to what Chelsea is saying about the productivity. Like there's a lot of tricks with the medication management with diabetes. These new medications, the GLP-1s, it's a new generation of medications that they also have a cardiovascular protection. So it actually minimizes the risk of cardiovascular conditions and other ones that are very expensive, but also a daily cost of living with diabetes is, even if people are very well managed with the existing medication, like for example, if they're on the older classes like sulfonylureas, and these are medications that produce more insulin, but people are at higher risk of hypoglycemia, which is low blood glucose. When people have low blood glucose, their brain is not functioning very well. When they're older people, it impacts cognition, can get them faster to the dementia. So it has a daily cost of managing. So that's why it's so important to work with Chelsea and pharmacists who understand the daily impact that medications, all the classes or not right medications for people with diabetes have an impact on their employment and family. So it's not just when they're at work, it's when they're at home. And then all of those approaches are being impacted by it. But I can tell you, it's when you ask, when we had a few studies, when we asked that people with diabetes, what's very important to them, number one is typically coming out medication and monitoring. So it has such a huge impact on people because we forget how that medication that they're taking, if it's a medication that is not very good for their body, is impacting their quality of daily living. If they get frequent hypoglycemia, they keep on drinking juice and eating in response to it. They come to us and we tell them, hey, by the way, you have to lose weight. And they cannot lose weight if they have a high blood glucose all the time because they need to eat in response to it to feed the medication. So it's very important to really help people to manage medications first before we even address lifestyle, nutrition, and other aspects. Medication and monitoring of blood glucose are the very important elements of self-care in diabetes.
That's
And
what
I'm a dietitian, and I can tell you that medication is more important than nutrition.
And I'd echo and kind of just reinforce again, for anybody that's on the call that's working in an HR capacity, reach out to your PBM, reach out to your broker. They will give you the data. This is just, it's such a field that's rich with data to support taking action. And they'll make it easy for you. And I know we've been fortunate to kind of partner early on with TrueRx, and it's really helped those moments that Barbara was talking about, where we have now a number of our employees are wearing the CGMs. They've got them on, they have it on their phone, they have it on their watch. We know what it is when we hear that beep when we're in a meeting. You know, and it's just really important, I think, to help create the awareness for how many people are in fact impacted, and being flexible from an HR practitioner standpoint. I think listening to your employees and soliciting feedback. Again, it gets a little tricky sometimes with HIPAA, but I've found, at least my experience, is people very much want to share what they're learning. You know, I had an employee call me and say, "You're not going to believe this. I went to the eye doctor. My prescription changed. You know, my A1C went down by, over 2.5, and now my prescription's changed. It's improved." And, it's great to be able to have those things to celebrate, but also maybe to give the folks that are on that cusp of not wanting to participate, it's a little bit fun. People are talking about it. There's some energy around it. It feels like an inclusive group. Oh, are you going to get one of those? Oh, I might. Are you going to get one? And we're the monitor. And so the technology is amazing, and the support that we have had to kind of reinforce why we're doing it, what the ROI might be. behind the scenes has been outstanding. So
Amy, that's what I love so much about the story at Cardon is that you're invested as a leadership team, and then that, you know, culture, we talked backstage, culture
Yeah.
starts at the top in a company. And so the fact that you all are so invested in your employees, but you're modeling that for yourselves and showing them, you know, the power of being able to monitor the, you know, for your employees.
yeah, I think half of our senior executive team is wearing the CGMs. I've got mine on now. I had the experience of not putting it on the right way the first time and learning that that can go awry, not very often, but I think I'm the one in a few that finds the wrong way to put those on, but now it can relate to what a participant might be going through when they have those experiences. And it's all about the data. I think we learned our partnership with, again, I know this is you guys, but Chelsea was great because we had a number of people that wanted to be on the program, but they were pre-diabetic. Okay, well, as an HR practitioner, be flexible. You know, look at your prior authorization and maybe we're going to include a different group of people now to make it more open to other people who want that data and are willing to use it to help with their overall health and wellness. So that was a big bonus for us.
Mhm.
Well, we've been kind of dancing around the topic. Let's dive right into what a diabetic management program might look like. You know, we have one at Rx. There's many out there. Chelsea, you know, the word wellness program, it almost became, you know, kind of a dirty word in our industry just because, you know, they weren't effective and people didn't want to invest in them. But as an employer, you need to show that you're investing in your employees. So tell us about the power of a clinical program that can specifically focus on a disease state like diabetes, and share a little bit of, you know, about the Rx diabetic program and how we do what we do.
Absolutely, absolutely. And wellness programs can be fantastic. I think they do a fantastic job when they encompass screenings for getting your members screened, bringing light to different conditions. But there is a gap there in where you take that screening and how deeply the program goes into helping patients with chronic conditions be managed. And a lot of wellness programs are, you know, log into an app, pull this up on your own. People don't have time for that. Or they don't know where to start to look at resources. So I would say first and foremost, finding a chronic disease management program or a diabetes program that is individualized for the member. I talk about a lot, not all diabetics are created equal. And they really need that individualized coaching to help them meet their goals. You know, our program doesn't just give some literature to a member and say, hey, read this, follow this, you know, this diet. We say, hey, take me through your day. What shift do you work? When are you eating breakfast? When are you eating lunch? When are you eating dinner? What do you like to eat? What do your meals consist of? Who are you cooking for? You know, kind of getting into those stressors of life so that we can make those individualized goals with the member and help them work on them until they see our dietitian or our clinical pharmacist again. So first and foremost, an individualized approach. And then also, you know, we do look at the member as a whole. We do a comprehensive medication review to look at those meds and make sure they're optimized. Are the members taking them appropriately? Are they even taking them at all? Just because we have a prescription claim doesn't mean they're actually taking them or taking them the way that they should. Are they having any side effects? You'd be surprised the number of members that we see that were started on a medication, but maybe never had follow-up and it's never been optimized. A lot of these medications, you know, you kind of have a starter dose that you are started at by a physician, and it's intended to be titrated to see those results that we see in clinical studies for various medications. That med has to be adjusted. So we are making a lot of interventions there so that, you know, if you have a patient on a GLP-1, for example, that's all the talk. You don't want a patient to start to continue on the lowest dose. That's a lot of waste in prescription benefit dollars. You are not going to see the benefits and that cardiovascular risk reduction and the benefits, the improvement in those A1C results unless that patient is optimized. So we're making a lot of interventions there. So I think without going too far down a rabbit hole, I think the number one recommendation would be something that's an individualized program. Group classes can be great, but a group class cannot have as much of an impact. We also have, we are a resource to those members in between their visits as well. So some type of program that's going to be a resource for the members that they can call in with questions. If they have a weird weekend and they want somebody to review their blood sugars, we have someone available to do that, which is really helpful. And we work as a liaison. You know, it's meant to be, I talked about team-based care. We want this to be a collaborative program with their provider. And we do that from the very beginning. When we have a member enroll, their provider gets information from us, talking about our program, explaining our program, giving contact information for our program if they have questions, and explaining that this is meant to be collaborative with their care. We've seen great results from our program. I am proud to say that our 6-month, for our members who are a part of the program for 6 months, when we look at that data, 80% of our participants have an A1C below 7, which is huge. We know that when an A1C is below 7, we significantly decrease that risk of complications for a person with diabetes. So we are very proud of that statistic. We have varying, you know, we see patients right now that are decreasing their medications. We help with getting patients on different medications. We look at the patient as a whole. So we're making sure their blood, not only are their blood sugars getting controlled, but also blood pressure. And do they need a cholesterol medication? Are they getting the recommended vaccines? So we are really looking at that diabetic patient as a whole and helping with control.
That is fantastic. I think it's really easy for us to tout, you know, we have a great diabetic program. It's very patient driven, one-on-one counseling, looking at the patient as a whole, medication, diet, all those things. But I wanted to hear from Amy, her own experience as an employer and utilizing a program like this. Again, there's many out there, but Amy, what has your experience been in what your employees have experienced, how you've benefited as a company? But really would love to hear your perspective on that.
Yeah, and I think so much of it is really, it's just foundationally what Chelsea said. It's an individualized program, which makes the person, they almost have to have their level of accountability and participation, and it's a great benefit. Again, you know, it's become kind of a topic, definitely a topic among our leaders, where they talk about the diabetes care program and, oh, have you had your appointment yet? How was your last appointment? Just kind of talking about that and understanding. I think it makes it more, it's more engaging to do rather than just, you know, you put the monitor on and you're watching on your phone, but knowing that you have an appointment and being able to keep notes and say, I'm going to get some answers to these questions. It may or may not be related. I had one employee who has a condition. They have a heart condition, and they were monitoring their heart condition with their cardiologist. And they said, you know, I need more. This was one of our leaders. I really want more health data. Can I get the CGM? They did. And they learned about the spiking that they were having after eating certain foods. And I know either Chelsea or someone on her team has worked with this individual, because they came back and said, I wish I had known this long ago. I had no idea that my body was reacting this way to these foods. And my cardiologist, I shared this information with them as well. And now we have a broader picture of my overall health and what I might be able to do to manage kind of my health journey with better data. And I think that might have been one of the points, because this individual was borderline even pre-diabetic, that we said, we need to go back and change this. Like, pre-diabetics need to have the same access to this information. And went through, again, Gallagher got involved, our broker, and they were helping us calculate, you know, the ROI. And we have a consultant, and he was helping us, and he said, you know, actually, Amy, the ROI on a pre-diabetic is higher than some of the diabetic estimates that we've seen. So it really opened our eyes and said, shoot, we were looking at this the wrong way. We need to be more inclusive. And again, giving that one-on-one attention is really, to me, the differentiator. When you can log in and be on a video call with someone with Chelsea's background that can talk to you about not just the results that are showing up, but what's going on behind that and what you can do to control it. It's really been a great experience. We're trying to figure out how to get more. I think if you ask me my biggest frustration right now, it's that we don't have more people participating that are eligible. So we're kind of working on communication strategies, again, being cognizant of HIPAA. How can we reach out and make the invitation broader? We have a lot of frontline healthcare workers that don't sit at a desk, that don't have a laptop. How can we reach out to them and get messaging to them about this? So we're having fun kind of challenging ourselves to do that. But it's definitely a differentiator, is having that human in live, at least video live, conversations with them about that.
Chelsea, what are your comments on that? So barriers for employers in getting their members involved with a program like that. Why are people hesitant, and how can you overcome it?
So we've talked about, it's come up from a top-down approach, like the culture from the top down, and we see where the messaging comes from that top-down perspective have better results. When members really hear, their employees really hear that their employer is invested in their health and promoting them to be a part of programs and investing the dollars into it, we see that that works the best. Amy's group has taken the perspective of true prevention. So we work with, I guess I should back up, we have prescription claims, right? So when the program is being used for diabetes, we help outreach those members who are filling a prescription for a diabetic medication and talk to them and get them resources to know that this program is available to them. It's no cost to them. It's covered by their employer. The pre-diabetes is a bit of a different beast because it's true prevention, and those patients may not be on medication. So we are working on strategies to help with that. But definitely when it's a top-down approach from a culture perspective and coming from leadership that they're supporting their employees to be in these programs, we see a much better engagement rate with those employers. Absolutely. And we are also seeing from our program word of mouth. When we've had some employers that members have been in it for 6 to 8 months and are seeing results and feeling better, we see an uptick later on of engagement because they're telling their coworkers about the program, which is really great.
Yeah, I've had the pleasure of hearing some of those incredible stories. Chelsea and the panel would love to hear some of the success stories you've heard or been part of. Implementing a program like this and how it's been changing the lives that you all work with.
Yes, we've had great success stories. I have had members I talked about the statistic. We are seeing a reduction in A1Cs, but what we're seeing more than anything is members are starting to wean off medications, or they're feeling better. I had an example of a patient who said, hey, for the first time in a long time, I went on vacation and I felt great. I was able to keep up with my kids. I would have absolutely had to take a rest day in there and not be able to keep up with my kids, but I was able to do that for the first time ever. And they knew it was because their blood sugars were well controlled. I have another patient who really struggled with hypoglycemia, so had a lot of low blood sugars, very much limited their activities in their day-to-day. And now we've adjusted their medications. They are engaged with diet now and understanding different food combinations to help stabilize those blood sugars. We're eating more whole foods. We're making sure we're getting protein with meals along with some carbohydrates, and it has very much stabilized her readings. And same thing, she is feeling better. She is doing more than she would have ever done. She says, I am going on walks now where I would have not gotten far from home because I was too worried about dropping. She is able to live her life to a much higher degree and enjoying life more. Those are the stories. We have lots of clinical statistics of what we're doing, but those are the stories that we feel like we're truly making an impact.
It was funny, Chelsea, I was in a board meeting yesterday and my CFO looked at me. We both had our lunches. They brought our lunches in and he and I were eating separately. And he's not even on a CGM. He goes, I guess I should eat some of my burger before I eat those fries, right? Like, aren't I supposed to have the protein first? And it's just those kind of conversations where you realize that you're you're having the conversations, creating the awareness, and hopefully making a difference. So
Changing the culture, right?
yeah, I mean, I look forward down the road to seeing, right, Adrienne, as we get into this, having it in place for a year or 2 years, if we start seeing an impact on the expense, or, you know, what the data starts showing as a lag effect of people entering into the program.
And I will add, we talked about the structure of a program and what employers should work or look for. I would say, look for a program that also shows you the outcomes. They are tracking that. They are not saying, oh, we engaged with this amount of members, you know, we had conversations with this amount of members. That's fantastic. But where are the outcomes? Are they tracking those lab results? You know, our next stage on top of that is we're going to track medical spend. We want to show that you're having a decrease in your medical spend because you are taking care of this population. So look, you know, ask those resources, or ask your broker to help you find a program that will show you the outcomes and track that for you over the course of time.
And I also want to add that you're not just investing in a person with diabetes, but also the whole family. Because the lifestyle changes that they're doing, it works as good as medication. So once they, you know, able to implement those lifestyle changes, then the daughter and the son and everybody, like Amy was saying, she doesn't have diabetes, but she's wearing the blood glucose meter. She's making that decisions and so on about food and lifestyle. So keep in mind that it's like that educational programs that Chelsea has described works as good as medication. And that's why those outcomes are important, because we know that the programs can lower A1C by 1 or 2 up to 3 increments. So if the programs do not have outcomes, it doesn't work. So it's just making sure that we look at that, but keep in mind that you're investing in a family and community, and not just with not one person, but probably additional few of them as a whole package.
Barbara, I love that comment to close us out. I think that is so important. At Rx, we say we're health strategists. We're here to help you turn healthcare costs into health investments. And that's exactly what we mean, is investing in the health of your employees. But to Barbara's point, it's not just your employees that you're investing in, it's their families. It's the people that they care about. So, you know, your employees are making the vision of your company come to life. They are the ones on the front lines, you know, working in your company day to day. Working with partners that are taking care of them and that are taking care of their families is so important. Not just to improve the bottom line, but, you know, to make people healthier, which will ultimately, you know, as a society, as an employer, that makes a big impact. So really want to thank our panelists today. You know, Amy, Barbara, Chelsea, you all, as always, do a fantastic job talking about this very important topic. I want to thank our audience for joining us today. We enjoy seeing your names pop up every month on our webinars. We know that we're making an impact as health strategists, providing relative content to you all. So thank you again for joining us. Chelsea, we have a very big event coming up with our partnership with the ADA. Do you want to share a little bit more about that?
Yes, absolutely. Absolutely. So we are partnering, you know, we care deeply about taking care of members with diabetes and their families, and helping equip our employers with knowledge. So we are partnering with the American Diabetes Association in Indiana to help them with the ADA State of Diabetes event. It's going to be November 20th, and it is for all employers in the state of Indiana as well as neighboring states. It is a great event for them to come to and learn about different resources that are available for employers to support their employees with diabetes. They'll receive a toolkit. Our own Eric Barker is chairing the event. We have a panelist of experts in this arena that will also give information to employees, but it's just a great way to gather resources and come back with some tools in the toolkit that you can think about implementing for your employees with diabetes. So that will be November 20th. I believe the link is going to be provided to help those with signups, but it's for all employers in the state of in the state of Indiana and surrounding states.
Excellent. We very much look forward to that event. If you would like to learn more about Rx or our diabetic program, please contact your health strategist. It's at diabetes@trx.com. Chelsea, I didn't realize we had our own email address for that, so that's great. We'll also be sending that link out. Please contact your account manager to learn more about that program or any other programs that we offer. Again, thank you to our panelists. Thank you to everyone who joined us today. Have a wonderful day, and we look forward to seeing you November 20th at the American Diabetes Association in Indianapolis. Thank you, everyone.